Expensive medical bills shouldn't stand in the way of your patient's health, which is why Medfem helps countless South Africans realize their medical dreams every day. Medfem provides life-changing loans for any medical procedure, treatment, or operation not covered by medical aid up to 100,000 Rand. Medfem is the only financier that specializes in medical procedures. We can finance the shortfall or the total medical bill and make split payments to the doctor, hospital or clinic, anaesthetist, and even medical device providers. Become a partner and enjoy all the benefits of our Medfem offering. Our service is completely free to our partners, and we make payment directly to you without deducting any commission. No more accounts receivable for your practice, ensuring you are cash flow positive. Simply refer your patients to apply online at Medfem. Patients only need to attach a quote or invoice from your practice to ensure we pay you directly. Join the Medi family today, the solution for you and your patients.
We are moving on to our next speaker, who is Dr. Nicholas Clark. He's a gynecologist for over 20 years, joined Medfem Fertility Clinic in 2012 as a director. Dr. Clark qualified from University College and Middlesex School of Medicine in London in 1990. His main interest has been fertility, minimally invasive, laparoscopic, these difficult names, surgery in particular, reproductive surgery, fertility, preservation, and problems traversing recurrent pregnancy failure and fertility. And Dr. Nicholas Clark is going to be talking about common IVF add-on treatments. Do you need them? Welcome, Dr. Clark.
Thank you for everybody who's listening, for giving your valuable time on a weekend to listen. My topic is common IVF add-on treatments. Do you need them? Some of what I might say falls into a bit of a grey area as to what an add-on is. We'll cover that as we go. So just to give an idea of what I'm going to do, I'm going to just obviously say who I am to some degree. Key messages, talk about what IVF is without add-ons. So we define IVF without add-ons, and then talk about some of the common add-ons. They're not all of them. And then summarize that, and you'll be very welcome to ask questions. So in terms of who am I, that question, that's one of the sort of great unknowns, but I can tell you what I do for a living, and that is that I'm a reproductive medicine specialist, having done obstetrics and gynaecology for many, many years. And I just put this slide up because it just is slightly random, but my journey, which was partly shared now, was that I trained at this institution in the 1990s. But I want this picture here is a hospital called the Hammersmith Hospital in London. And two of the add-ons that we now use, or we could discuss whether they are, in 1992-93, when I first started my fertility training, really, as part of general gynaecology, were in their infancy. And those two add-ons were what we now know as pre-implantation genetic testing. At the time, it was pre-implantation genetic diagnosis. They were playing around with the idea of being able to test individual genes in an embryo for people with certain diseases. And that was performed for, I think, the first time at the Hammersmith at that time. And the second one was that there was a drug at the time that was experimental. And none of us had any idea, obviously, years later, what would become of it. And it was a drug called etosiban. And it was not called etosiban at the time, it had a number. And we were involved in the randomized controlled trials to test that drug at the time for premature labor, uterine relaxant. And that's now become a major drug specifically for premature labor, but we also use it extensively in IVF. So just some random facts about the journey. So in terms of key messages, IVF really is a very evolved therapy. It's been around since 1978. And really by default, like anything in life, it has trends. And those trends include add-ons and subtractions. So an add-on, and this is an opinion, is not necessarily going to improve the final outcome. In other words, what we would consider to be the gold standard, which is a live birth, or the likelihood of delivering a baby. Because in theory, if that happened, then they would cease to be an add-on, and they would be, or they should be, part of the standard protocol. So probably they more often than not impact the journey rather than the final outcome. And this is a very key point that we will possibly come back to when we discuss specific add-ons. So what is IVF, which is free of add-ons? And again, this is an area of debate, but just to keep it simple, there are really three processes at play. The first one is stimulating the ovaries using hormonal medication in the form of injections. And basically, the idea is to stimulate the ovaries to produce multiple egg follicles and then retrieve those eggs that are within those egg follicles. Once we retrieve the eggs, the second part is then to fertilize them. And there are different ways of fertilizing, but primarily a form of sort of natural fertilization in conventional IVF, and then something known as ICSI, or intracytoplasmic sperm injection, really primarily for sperm issues. And then the third part would be to transfer these embryos. Now, sometimes we transfer embryos at the same time in what we would describe as a fresh cycle, or sometimes we temporarily freeze or cryopreserve the embryos. And this might be for reasons such as somebody who's producing too many eggs. We know that the IVF success rate, if you produce 20 or more eggs in a cycle, starts to decline if you do a fresh transfer. We know that there are certain hormone levels that if they are raised during the cycle, the success rate starts to fall away. So there are some quite rigid criteria that allow us to advise whether a fresh transfer is going to maximize the success or whether we do what we call a frozen transfer at a later date. But I want you to remember what I'm going to tell you now while we are talking about these add-ons. The main variables in all of this are not about the medical side. They are the egg that we receive, the sperm that we receive, and the uterus that the embryo will be finally, or the state of the health of the uterus that the embryo will finally implant in. So these variables are brought to us. And obviously, in terms of the egg and the sperm, an egg and a sperm fertilizing successfully will create an embryo. And I'm going to give just general figures here, but about 1 in 4 to 6 eggs might result in an embryo. We're really talking about day 5 embryos. They're known as blastocysts. And then just in terms of success, again, these are very general figures. They're population figures because they obviously vary depending on why somebody is present. But just from an age point of view, a woman under the age of 35, or eggs that are from a woman under the age of 35, if they get to the embryo stage, have about a 33% chance. About 1 in 3 embryos will result in a live birth. At the age of 38 to 40, that drops to about 1 in 5. And then from 40 onwards, about 1 in 10 embryos will make a baby. And this is just normal population figures. About 70% of that, and again, I'm just giving a rounded figure, but about 70% of that success to reach the live birth is in the embryo. And about 30% may be related to other factors. So the bit I want you to remember is that the strongest variable in all of this is the potential of the embryo. And the second is the uterus. And Mandy, in her really excellent talk before me, mentioned about really optimizing for IVF in various ways. And optimization includes the environment, the uterus. That's what it's all about. And you know, if we were to look at the physiology of a lot of what she was talking about, you know, we're talking about a sort of a pro-inflammatory environment being sort of neutralized to a less inflammatory environment. So that's just kind of to give an idea of the main variables. So what are some common add-ons? So I've picked, there was a study from Australia just recently. They looked at 21 add-ons. It was a little bit loose in the criteria, but I'm not going to bore you with 21 add-ons. I've picked a few that are fairly well known, and some of them you may have come across, and others you may come across, or they will maybe fall into the backgrounds. But the first one I'm going to talk about is time-lapse imaging, and then go on from there. So what is time-lapse imaging? Time-lapse imaging is basically a procedure whereby an embryo in an incubator or fertilized egg in an incubator is observed by serial photography, and the development of the embryo is followed. And using artificial intelligence and various algorithms that are often calibrated to the specific unit, it helps to assist selecting an embryo. We know that an embryo that follows a path in a sort of a reference sense to development, in other words, it becomes a blastocyst at the right time, is going to have a higher chance of resulting in a success than an embryo that is, for example, very, very slow, or even an embryo that may rush ahead in the beginning and then implode. So that's the theory. Now, clearly, taking photos of embryos has no impact on the embryo itself. So it's not the photography or even the AI that is necessarily what it's about. But there was some fairly clear evidence that the idea of just leaving an embryo or leaving fertilized eggs in the incubator, not disturbing them, trying to keep the environment as constant as possible, actually in itself resulted in a higher success rate in terms of outcome. The other point is that you don't discard embryos based on AI or time-lapse photography. So you may implant the embryo that's followed the closest path to success from the software's interpretation point of view, but then you will freeze any other viable embryos. And if for some reason that one is not successful, then you will transfer those. So in a sense, you know, one might question what the value of time-lapse would be, because ultimately, as we will repeat, if there is a viable embryo that's going to make a baby, then you will come across that embryo with cumulative transfers anyway. So the end result, as we said at the beginning, is going to be the same, but the journey might be slightly different. The second one is something called assisted hatching. And just in terms of a bit of physiology, I haven't got pictures, but basically an egg is surrounded by a shell, just like a human egg is surrounded by a shell. It has a fancy name. It's called the zona pellucida. And when you fertilize that egg, the development of the embryo is within that shell. So everything you see on here is still within the shell. And this is a blastocyst, so a day 5 embryo, which in the main is what we deal with nowadays in terms of transfer. And this structure has several hundred cells. So from one cell in 5 days to several hundred, maybe 200-300 cells. And it's still within that shell. And sometimes that shell is thought to be slightly hardened. And if you look at this embryo, this is what we call hatching. This is the inner part of the embryo basically breaking through, just like what happens in an egg when a chick delivers or whatever. But basically, the egg, the shell breaks down, the inner cell mass comes out. The baby develops from an area inside the embryo which is known as the inner cell mass, and the rest into various other structures. Now, assisted hatching is the idea of lasering that structure to make it easier to hatch. And there may be some groups that benefit from that. So some units have adopted certain categories. So you could argue it's not an add-on in some units. It's done routinely, as I was saying earlier, as things seem to assist. But it's certainly not a universal addition that we know to be beneficial. Embryo glue, a lot of you may have heard of glue. It's really a colloquial term for using hyaluronan, which is a very natural substance in the body, and fairly universal. Basically, you put the embryo in this glue, you leave it for a period of time, about 30 minutes or so, and then transfer the embryo. And there is a mixture of evidence. There is evidence that shows benefit, and there's evidence that not. And again, in some clinics where there's been benefit seen in some groups of patients, then it's sort of been adopted. And again, it moves from add-on to being more of a recommended standard protocol. So individual advice would depend on what the particular outcomes in the clinic would be. I'm not going to say too much about oocyte activation. It's something not particularly common in South Africa, but basically it's the idea of priming the egg before fertilization. If you go to YouTube and look at the spark of life, it'll show you a video of the point of fertilization represented by light, and it's quite interesting. It's a very active process. So there are things you can do to the egg in order to prepare it for, or to improve fertilization rates, particularly with the ICSI, which is the injection of sperm into eggs. And it's mainly related to some of the chemicals which are moving across the shell, the membrane that we talked about earlier. Something which is more widely known probably is something called endometrial receptivity assays, or ERAs. And this is a really interesting development. But basically what it is using a genetic method where you take some cells from the endometrium or the lining of the womb where implantation occurs at the same time that you would have done a transfer. So you simulate the cycle for transfer, and you genetically test those cells, and you compare an array, meaning that you're testing a number of individual genes with a so-called norm, and you see how that deviates or not, and then you can basically decide whether the window of implantation corresponds to an average, which is about 5 days after ovulation, or it is earlier or later. And then you can time your transfer according to the array. And again, there is some evidence that there may be some benefit to small groups of women who are, and primarily this was a test developed for people who have a problem. So they are already a small group of people with a recurrent implantation failure, and this means sort of 3 or more transfers that may have been unsuccessful, and out of those group, a few of them may show a shift. So it was never really intended to be a routine test for people who are undergoing routine IVF. Unfortunately, or maybe that's not the right word, but as happens much of the time, a lot of these tests become popular and they start being incorporated into normal practice, and it's very difficult to stop that from happening. But it is not evidence for that, and in my experience, and I think not just mine, some of the outcomes are of debatable significance, because we may get the result, but it doesn't result in a positive outcome, or we may go back to a window that might not correspond with the test, and we do get an outcome. So it's an interesting test that needs discussion. Something that's much more... sorry, I just want to get to the next slide. Where's the next slide? So another test that's probably very well known is pre-implantation genetic testing for aneuploidies. This is testing embryos for just their chromosome structure, not for specific medical disorders. And this is now very widespread. I'm going to just say a few things on this, but basically going back to what I said earlier, 70% of the outcome potentially is in the embryo. So if you know that an embryo is chromosomally normal, by this test, you would expect that the implantation rate is higher when you put that embryo into the uterus. And indeed, that's what we see. It's about around 65% or so. And that is age unrelated now, because the same potential, whether you are 25, 35, or in the 40s to some degree, assuming the uterus is healthy. But it does not change the embryo. So that embryo is now is the same embryo whether you tested it or you didn't. So the positive pregnancy rate is one thing, and but the live birth rate is another. So if pregnancy occurs, there are benefits, such as the idea of a reduced miscarriage rate, because we know miscarriage rate is linked to chromosome abnormalities, so you will reduce the miscarriage rate. But you still need multiple tested embryos to get to very high success rates. If one is 65%, then the cumulative success after is somewhere around 3 to 4 embryos to start reaching figures of beyond 80%. And that's the same for untested embryos. If you look at what we said earlier, 3 transfers in an under 35-year-old with untested embryos has about a 68% live birth rate. So compare. Obviously, younger women have a default high pregnancy rate, so therefore you can argue that the test has different significance in these people. And then we worry slightly, and this is again just putting the test under scrutiny, that these tests you can get normal embryos that are abnormal embryos that are normal, and therefore there's a concern about discarding embryos, which I'm not going to go into today. It's a technical topic. But the point is, one needs to look at all of these things with a critical eye and give a balanced opinion. Endometrial scratch, I'm not going to say much about this. You may have heard of it. It's the idea of scratching the endometrium, which literally means poking a little catheter into the uterus and irritating the uterus to cause a sort of an inflammatory type response. And that may improve implantation. The evidence is quite poor. It was quite trendy for a while. I think it's a little bit less trendy now, but you may hear about it. Platelet-rich plasma, I'm not going to say too much about this. This is the sort of something that's being injected into every part of the body for all sorts of different reasons. Basically a blood sample that's spun down to concentrate platelets. And again, it's related to an immune response. And we won't go into detail for there, but it's just interesting that one of those things that you might come across. So, just to summarize, add-ons are generally, they're not harmful in the main. Obviously, they shouldn't be harmful, otherwise you should not be doing anything that's harmful. Placebo is an interesting topic. We won't go into that, but it's quite hard to separate sometimes. They do cost. They may change the time frame, and one needs to have individual critical assessment. So changing the journey, like I said. PGTA in particular may have very specific reasons that somebody would want it that's not about the live birth, but about that journey, which, again, we can talk about. Then, obviously, we worry sometimes that people are quite impressionable, so we have to be very cautious of when we are talking about these things, giving a balanced opinion and not a biased opinion. So just to summarize the last comment that, there are many exciting developments, but over the years, a few of them have remained our staple protocols, and for a very good reason. So very few things come along and suddenly revolutionize what we do. And nature is a very big part of this, which is a good thing, not a bad thing. It's actually a very good thing. So concentrating on what we know gives us a higher success rate, and in my view, change for the sake of change is not a good thing to do. Thank you very much.
Expensive medical bills shouldn't stand in the way of your patient's health, which is why Medfem helps countless South Africans realize their medical dreams every day. Medfem provides life-changing loans for any medical procedure, treatment, or operation not covered by medical aid up to 100,000 Rand. Medfem is the only financier that specializes in medical procedures. We can finance the shortfall or the total medical bill and make split payments to the doctor, hospital or clinic, anaesthetist, and even medical device providers. Become a partner and enjoy all the benefits of our Medfem offering. Our service is completely free to our partners, and we make payment directly to you without deducting any commission. No more accounts receivable for your practice, ensuring you are cash flow positive. Simply refer your patients to apply online at Medfem. Patients only need to attach a quote or invoice from your practice to ensure we pay you directly. Join the Medi family today, the solution for you and your patients.
Egg chromosomally, it would result in the destruction of the egg. So it's not a practice, you cannot do that. But it's embryos.
So it's not possible to test the eggs? It would
Well, you would have to,
destroy-
because you're talking about half the genome, so half of the chromosome complement, but in order to extract that and test it, it would result in the destruction of the egg itself. It's a single cell.
Okay, but
And-
we can talk about egg quality. So is that not linked to the chromosome?
Yeah, so in terms of egg quality, there's no direct test for egg quality apart from performance. An egg that is normal is going to perform, but you only know that retrospectively. So there is not a test for egg quality. We know there are markers. Age is the most specific marker, and then there are various tests about function of the ovary and reserve in the ovary that help us to try and fine-tune what we think the egg quality might be in somebody of the same age. But age is the key egg quality marker. Those stats I told you are very general, but they are across the, essentially across the board.
Okay, thank you.
Hi, sorry. I think really Kelly behind you at Next Biosciences will be able to answer your questions, and she is available for a one-on-one at about 11:15, Kelly, if you'd like to go to the specialist chat zone and have a chat with her. Okay, perfect. Excellent. Thank you, Dr. Clark. I've got a question for you, though.
Oh, yeah, okay. Oh, no.
Oh, no. Okay, so out of 10 consultants, how many more patients would you be able to assist if you offered them a repayment option through Medfem?
Yeah, that's a very difficult question to answer. Look, I think there's a lot of people out there who don't have access, unfortunately, to what we do, and they should have access. I mean, in theory, there should be universal access, and, fertility is like any other medical disorder. It deserves a much more widespread implementation. So a lot is the answer. But I think, a big barrier is funding.
Yep, it is. And that brings me on to the next question. What procedures are covered by medical aid?
So look, there are some medical aids that cover IVF treatments now, which is good. There are some that have covered for a while, and there's some new, or not some, but there a new medical aid that has come on board, and hopefully that will be a message to others. So in those medical aids, our IVF procedures pretty much fully are covered, without add-ons that don't add to the outcome. And then there are other parts of the treatment that is covered by a medical aid. So things like consultations and scans and various other things. I'm going to be honest, I'm not an expert on coding or any of that type of thing. So what people get maybe would be best asked to somebody who's more on the finance side.
There will be a talk tomorrow about prescribed minimum benefits and how to claim from your medical aids under the Prescribed Minimum Benefit Act, that you can claim for consultations and diagnosis of your infertility without it coming out of your medical aid savings. So please don't forget to join us tomorrow. That talk is very important. Thank you, Dr. Clark. We appreciate it.
Thank you very much. Thank you very much. Thanks for you listening.